Hello, everyone. Thank you so much for joining us on this, at least in upstate, glorious sunny Friday as we're entering into the holiday season. My name is Jen Meredith. I'm one of the co-directors of Cornell's Center for Health Equity, and I'm located on the Ithaca campus in upstate New York. I have the absolute pleasure today of introducing our speaker, Dr. Brita Roy. Please bear with me as I introduce her, share a bit of her bio, and then I'm going to pass the baton over to her. So Dr. Brita Roy, MD, MPH, MHS, is an associate professor in the Department of Population Health and in the Department of Medicine, the Division of General Internal Medicine at the New York University Grossman School of Medicine. Dr. Roy is also Director of Community Health and Clinical Outcomes and the program called Beyond Bridges, a transformative initiative to improve population health and well-being among a diverse immigrant community in Brooklyn, New York, through community clinical partnerships. Dr. Roy co-developed the actionable collective well-being theoretical framework that adapts a positive health paradigm to the community level to improve population health. Her scholarly work tests this framework using epidemiologic methods to identify positive psychosocial factors that promote health and health equity, and applies community-based implementation science and systems science approaches to design and test strengths-based interventions to foster better health outcomes. Currently, Dr. Roy co-leads the Collective Well research team and previously co-led the Institute for Healthcare Improvement's 100 Million Healthier Lives measurement team and served as lead faculty for their Pathways to Population Health Action Community. Additionally, Dr. Roy enjoys caring for patients and teaching medical students and residents as an academic hospitalist. Dr. Roy received a Bachelor's of Engineering from Vanderbilt University, followed by a Master's in Engineering from Wayne State University. She then completed a combined MD and PH at the University of Michigan before completing residency and chief residency in internal medicine at the University of Alabama at Birmingham. Dr. Roy was a Robert Wood Johnson Foundation clinical scholar at Yale University from 2013 to 2015. And with that, I'm going to pass the mic over to you, Dr. Roy. Thank you so much for being here with us today.
Great. Thanks for having me. I'm excited to be here. Thanks for the introduction. All right, I'm do the scary thing of trying to share my slides. Okay. Are you seeing a screen that says using participatory system science? Yes, and it's the correct screen, not the presenter view. Awesome. Okay, so I am a general internist and health equity researcher and really have been increasingly been utilizing system science to design and implement interventions to address public health issues. And so today I plan to share with you two examples of how I've done that. And I'm going to assume that the majority of this group is not super familiar with system science approaches. So I am going to walk you through, some like introductory 101 information or a crash course to system science. So in our hour today, we'll cover that intro to system science approaches, and then also just briefly when and why it is useful to use participatory system science approaches. I'll walk you through two examples I have used to address complex public health challenges. The first one is around community gun violence in the city of New Haven, Connecticut, where I was for about 10 years prior to moving here. And the second one is developing a community clinic linkage actually here in Brooklyn, New York. Finally, I hope we have some time for Q&A. Please do feel free to put questions in the chat as we go along. I probably won't be able to see them while I'm doing the talk, but I can see them at the end. And then at the end, I think we'll also, if you want to just unmute yourself to ask questions, that will be fine as well. Also, along the way, if something's not clear and you have like a clarifying question that would be helpful to ask right then, please, I welcome you to unmute yourself and ask. Again, I won't probably be able to see the chat, so just go ahead and unmute and interrupt. All right, so without further ado, intro to system science. So complex systems modeling is really a diverse set of mathematical and statistical computational techniques that generate insight into how complicated systems work. And they can be physical systems, natural systems. Many of these approaches kind of started out in engineering and then ecology, and subsequently have been applied to many other things now, health systems and public health systems. There are multiple different types of modeling approaches. I will be talking about system dynamics modeling and a little bit about social network modeling today, but there are also agent-based models, discrete events models. You can also do combinations and create hybrid models. So it's kind of a whole field in and of itself. And those quantitative models can be informed using participatory approaches. So again, very like traditionally, historically, there may have been, an engineer in a room really constructing the model by themselves. But especially if we're talking about really complex public health issues, it really requires knowledge of many different types of people seeing the problem from different perspectives. And so there are really structured processes like group model building to systematically diagram this complex system. And it ends up being a qualitative model that's generated from these group model building sessions. I'll show you some examples. But by engaging those diverse stakeholders with diverse perspectives, you can really collaboratively create a more complete picture that then you could translate parts of into a quantitative system model to really understand the dynamics of the problem, as well as even simulate what potential interventions might do, and especially thinking about a public health context. It's really time consuming and resource intensive to implement interventions in the community. So by using a simulation model, you can sort of test in silico, what might happen 10, 20, 30 years from now if we implemented a certain intervention. So I'm going to walk you through again. This is just like, 101 cause loop diagramming, what the notation looks like, just to help you understand some of the diagrams later on in this talk. So causal loop diagramming, again, is qualitative. And what we do is link factors that are associated with each other causally. So that can eventually create feedback loops. And these are two very simple ones where the amount of food ingested is linked to the amount of hunger you have. And because the more food you take in, the less hunger you'll have. That's denoted with a minus sign. In other words, the two factors go different directions. One goes up and that pushes the other one down. But the more hunger you have, the more food you ingest. And so you can see a plus sign here, which just means these two things go in the same direction. More hunger means more food ingested. So that loop is a balancing loop. In other words, you can think about it like a thermostat, right? If you get too hungry, you'll eat, and that will then reduce the amount of hunger you have. So it kind of tries to balance itself out or at a certain set point. But there are other types of loops that we call reinforcing loops, where each factor overall actually increases the other. So in this case, we can talk about smoking, and the more someone smokes, actually, the more nicotine addiction they have, the more addiction, the more smoking there is. So that is called a reinforcing loop. And it can get much more complex, certainly, than that, right? So here, again, you see that nicotine addiction and smoking, but there are other factors associated with smoking, not just the amount of addiction. So there's a social aspect to smoking, where time spent around other smokers also increases the closeness of relationships socially with those smokers. And that can be another reinforcing loop that perpetuates smoking. But in the long run, and these little hash marks signify a delay in time, over time, smoking can have a negative impact on health and worsen health, which then can increase commitment to sensation and feedback negatively on smoking. So that can be one way to reduce smoking levels over time. So you'll see that again later that these diagrams can become very complex, and that's the reason to do that, is to really kind of untangle all these different factors associated with a complex public health issue. So you can start to maybe tease out where it might be effective to intervene. So causal loop diagramming is qualitative. And I mentioned that system dynamics models and other types of systems models are quantitative. And so to make things quantitative, we need amounts, we need numbers, we need rates. So in system dynamics modeling, we talk about stock and flow models. And I think the easiest way to think about those is a stock is an amount of stuff. So a bathtub, right? So it can fill up with a certain amount of water, right? You can talk about gallons, right? The number of gallons in a bathtub. And the amount of water in that bathtub, the number of gallons, is really dependent on the rate of water coming in through the faucet as well as the rate leaving through the drain. And so we talk about the bathtub really as a stock. You have an incoming rate as the inflow and then the outflow. And so in systems dynamics modeling notation, these squares are the stocks. So there's your tub, and these are the rates. It actually looks like a little valve, inflow rate and outflow rate. And behind these are differential equations. And so you can actually graph changes over time and have things that actually influence the rate. So in this case, how much is the faucet turned on, or how clogged is the drain? And so this is kind of, just a very simple example of what it can look like, where if I have the faucet turned on at, let's say, 5 gallons per minute and the drain draining at 2 gallons per minute, then you will have really a steady rise over time in the number of gallons in your tub, unless you change one of those numbers. So that is super simple, basic intro to systems dynamics modeling. All right. So when and why should we use participatory system science? Well, I like to think about, like I said, complex public health issues, or wicked problems. And wicked problems are social or cultural problems that feel really difficult or impossible to solve. Right? They feel really intractable. And usually that's because of its complex and interconnected nature. Wicked problems lack clarity in their aims and solutions, and they're subject to real-world constraints, which hinder attempts to find a solution. And that's called policy resistance. So policy resistance is the failure of really rational policies and policies that might even have good evidence behind them to achieve the desired outcomes. And so it occurs when there are other actors in the system that resist the policies placed on them. So one example I like to use is, is the example of food deserts, right? There's a lot of data, a lot of studies that show that people who live in communities that are considered food deserts or even food swamps have higher rates of obesity. And this is because they just don't have access to healthy foods. Okay, so a very rational solution can be to put a grocery store with healthy foods in the middle of that neighborhood, and we might expect eating behavior to change and obesity rates to go down. But studies have been done, that show that type of intervention does not always result in healthier eating, better health outcomes, lower rates of obesity. And it's because there's many other things in the system, like culture or the cost of food and what people are familiar with, or time, that influence eating behaviors. So just simply physical access to the food does not result in the outcomes we thought that it would. So systems thinking is really an approach that helps to delineate these various factors. And it contrasts with traditional analyses that tend to study systems by really trying to break them down into their separate elements, right? Like often we're looking for the independent effect of variable X on Y. This is really much more of a holistic approach that focuses on a way that the system's parts interrelate and how the system itself works over time and within the context of the environment. So it's much more focused on the structure and relationships between the parts rather than the kind of magnitude of associations between any two given parts of a system, and therefore recognizes that the system is much more than the sum of its parts. So it can help us really understand reasons for and potentially even overcome a seemingly underlying policy resistance. So in sum, participatory system science is a tool for collective theory building. From especially that qualitative sense, it can help to develop a shared mental model of the structures that might be underlying the wicked public health problems in our society. Group model building itself is a very structured approach to define a complex problem, understand the underlying structure that gives rise to the problem using maps and models, and then you can actually analyze the maps and models to determine new strategies or perspectives on how to solve that problem. So purposes for group model building can include discovery, right? So identifying new ways to do things, new places to intervene, expanding perspectives. So especially because we really try to include people with different perspectives on the issue, it can really allow, again, for a structured process for people to hear each other and hear how other people might view this problem. And with that, can develop collaboration consensus that might be needed for next steps to actually implement an intervention. Of course, it can help with analysis of the problem and also restructuring an existing program or existing system or prototyping new ones. All right, so if I haven't lost you all, we're going to go in to the first example, which is addressing community level gun violence in New Haven, Connecticut. So this was considered a wicked problem and really still is in New Haven, Connecticut. So back in 2011, there was a major uptick in the number of homicides in the city. And that really galvanized the community and they wanted to act. And so at that time, we formed a community academic partnership to really start to think through what is the best evidence? How do we actually intervene on this issue? And I'll kind of walk through kind of what we did over the subsequent, 10 to 15 years. But you'll see gun violence, even though there was that big uptick, there's probably some both regression to the mean and some impact of interventions that were put into place. But then certainly during the pandemic, many places in the country had a rise in gun violence, but you'll see the rise actually started before that. And the rates are starting to come back down, but it is definitely a major issue. And you'll see this is a map of New Haven, and these are each the different neighborhoods in New Haven, and like many other places in the country, there is inequity in rates of gun violence. And you'll see, these rates of violent crimes in some of these neighborhoods are, 20 to 21 per 1,000 residents. National rates are 2.5 per 1,000 residents. So it is really a major issue. We did initially just some focus groups with community members who just shared, how much of a toll this really takes on them. So I'm just going to read this quote because I do think it puts the work into context. "It took so much for me to not break down crying. I know firsthand what it feels like to live in this war zone. It affects me psychologically, emotionally, mentally, physically, and socially. I do so much work in the community, but when I go home, my outreach efforts stop and I hide in our apartment and don't engage with my neighbors at all. I am traumatized. I know how much I needed for someone to go door to door to see if families and children were okay and needed to talk." And so we got our first community partnered R01 from NIMHD, which really was a planning grant where we leveraged social network science and what we call positive deviance approach, as well as group model building, participatory systems science, to get a better understanding of ways that we could leverage resources in the community to develop a feasible intervention that we thought would really work in this community. So the first aim was using social network analysis, where we created the social network map using incidents of co-arrest, where each node in this network represents a unique individual, and the ties between individuals are incidents of co-arrest. So red nodes represent individuals who are victims of a fatal or non-fatal gun injury during the observation period. So the majority of the gunshot victims, 62%, were located within this network. And the network further shows that gunshot victimization was clustered in these co-arrest cliques meaning that most gunshot victims can be located in parts of the network with other gunshot victims. And approximately 150 individuals who have not been victimized are also directly connected to a gunshot victim. And so more than 350 people are really indirectly connected to victims, so essentially they're like a friend of a friend. And so we use a model to understand kind of who is at high risk, who is a friend of a friend, and it still has the same risk factors, but who have not been a victim. And we interview some of those people to understand, even though they had all the same risk factors, they're still in the same social networks. How is it that they kind of protected themselves? What resources did they use in the community to really kind of steer clear of violence? We did the same thing using a spatial analysis. So that was like, person-to-person social network. We also used a positive deviance approach, looking at neighborhood blocks. And so these figures show the residual values from a point process model of gunshot violence in New Haven between 2011 and 2016. And in the picture, the purple areas represent areas where there are fewer victimizations than the model would expect. And then the yellow is the flip, where there's more victimizations than the model would anticipate. And so we could actually, again, interview people who either live or work on blocks where the incidence of gun violence is lower than expected, and ask them, again, what's sort of different about this location compared with like the block, one block over, that has lower rates of gun violence. And so from those interviews of people that either were in that social network and not involved in violence, or lived or worked on blocks with lower rates of gun violence than expected, we elicited themes at the community, neighborhood, and interpersonal levels. At the interpersonal level, people really felt like role models were very critical, especially for youth, to disengage or not engage in violence. At the neighborhood level, social cohesion kept coming up time and time again. Like knowing your neighbors was really important. And they would talk about how there used to be a time when most people like owned their homes and so stayed in the neighborhoods and knew everyone. And therefore, they would intervene if they saw something, that wasn't right. And that has changed. And now people can't own homes, and there's a lot more turnover, and therefore less social cohesion. And then finally, at the community level, they talked about, again, some key community-based organizations, some of which no longer exist, but that really acted as anchors in the community to help develop that cohesion, and also had youth programming to keep youth sort of off the streets was kind of what they said. But basically having things for youth to engage in that interested them, that wanted to be part of, so people didn't get engaged in gun violence. And so we use this information to start mapping out our community as a system. Again, applied system science, acknowledging that firearm violence is not an individual level problem. It's really the communities that provide the context within which persistent firearm violence occurs. Even at that time, multiple interventions had been tried, but we recognize that violence persists, so it fit the definition of a wicked problem. And so we used participatory systems science to design a community-based intervention to mitigate gun violence. So we engaged a multi-stakeholder community group from New Haven in a group model building process. We used the resulting causal loop diagram and system dynamics model to identify key leverage points in the system that are likely to kind of change the trajectory and act on multiple parts of feedback loops in the model to reduce rates of gun violence. And we're now in the process of implementing and testing those interventions in our community. So, as I mentioned, group model building is a participatory approach to systematically diagramming a complex system. It's a scripted approach to engaging these diverse stakeholders with different perspectives on the problem. And the reason it's really systematic and scripted is to make sure it's there's equitable participation. So everyone is able to contribute their own perspective. And so again, the reason it is so useful is that, just like these scientists around the elephant, right? Each blindfolded scientist is like absolutely confident that they are able to identify the object that they are feeling in front of them, right? It's their own mental model of this intractable health problem. But the truth is that none of these folks have the full picture, and it's the combined picture that's much more likely to be accurate. And so we engaged multiple stakeholders in this group model building process, including people living in neighborhoods experiencing high rates of gun violence. We had leaders of community-based organizations working to mitigate the incidents and effects of gun violence. We included people from law enforcement, education, the business sector, healthcare, mental health, housing, and several others. A total of 14 people, all from really different sectors that interface with gun violence. And so this group participated in 3 half to full day workshops, during which we elicited community factors that the group felt were causes or consequences of community gun violence. And then we began to map them into a causal loop diagram. We came back a second day to really refine the diagram and talk about people's hopes and fears about the process. And then finally, actually started to use a model to brainstorm ideas for change and how impactful and feasible they're expected to be. So again, I'm going to walk you through this. And these were all the different variables that the group elicited, kind of grouped into themes. There was round robin elicitation of the variables, again, to really make sure everyone is able to contribute equally. And we just organized them into groups to make it easier to see. And then the group actually voted on the variables or groups that they thought was most important, kind of to focus us at the start. And so then we literally started mapping, one to the other. I don't expect you to read this. I have a cleaned up version for you all to see, but this is kind of what it looks like, right? It's a little messy up there. I'm at the board and linking one thing to another with those plus and minus arrows. But in the end, we came up with a causal loop diagram that really demonstrated, the system of drivers and downstream consequences of gun violence operating on different time horizons. So to better illustrate the key interactions and loops of the system, I'm going to use an iceberg analogy because we found one key loop that's sort of above the surface with short-term effects. And then we found several loops with longer-term effects that are below the surface and can generally be more difficult to see. So starting above the surface, this model's upper layer really focuses on control measures, right? They're policing, incarceration, and regulation that are organized into 3 balancing feedback loops. So gang involvement raises crime, violence, and gun ownership, which fuels gun violence. That rising violence actually triggers police activity and surveillance intended to then reduce crime and violence. So that's that first balancing loop right here. But then we have a second balancing loop where more policing actually leads to more incarceration, which can temporarily reduce gang involvement and gun violence, reinforced by tough on crime policies. And then finally, this third balancing loop related to gun ownership, which is shaped by inflows from outside communities as well as the strictness of gun laws, which drives violence. So as violence increases, police policies aim to restrict firearm access to lower future incidents. So all of these above the surface loops really seek to stabilize the system, right? By suppressing violence directly, either through incarceration or trying to reduce access to guns. So it reduces gun violence in the short term, but as you'll see, they might carry risks or unintended consequences in the long term. So this is where we start to get to some of those long-term reinforcing feedback loops, right? So incarceration might temporarily decrease gang involvement, but can ultimately increase it because we learn that there are gang connections that can be created in prison. So again, an unintended effect that prison often actually strengthens gang connections. So that's reinforcing loop number 1 here. or more willingness to engage with gangs even when people are released. So that leads to heightened post-release gang involvement and perpetuates the cycle of gun violence. Gang membership is also often a survival strategy, especially for those re-entering community without a solid plan or re-entry plan. And they're facing many unmet basic needs like housing instability, economic insecurity, and limited access to mental health care. So that's that second reinforcing loop. So strengthening structural support like job training, financial education, and affordable housing could potentially address these underlying drivers and actually break that reinforcing cycle of gun violence. So tackling some of these less visible systemic forces is really critical for long-term solutions. So this is a second sort of below the surface part of the model, which highlights how structural disadvantage, stigma, and stress fuel cycles of community gun violence, which really extends even beyond gang involvement. So living in low-income areas exacerbates challenges for individuals released from incarceration who often lack that critical reentry support. So this results in social stigmatization, that's that third reinforcing loop here, limited access to services, and barriers to reentering the workforce, which reinforces economic and social disadvantage. There are unmet basic needs, which worsen vulnerability to stress and escalate conflict, despair, and increase gun violence here. And so substance use, especially alcohol, further contributes to violence and injury back here. And so participants in these sessions really emphasized implementing mental health care, substance use treatment, and mentoring programs to disrupt these cycles. And mentorship can additionally foster educational achievement, positive norms, and protection against gang involvement, which reduces violence in the long term. And then finally, this is the last part, which we're calling below the surface 3. This part of the model highlights how community trust, cohesion, and perceptions of safety shape long-term gun violence. So participants noted that increased policing and stigmatization of formerly incarcerated individuals really erode trust between communities and law enforcement. So that's the reinforcing loops 8 and 9 here. And that weakens social cohesion and actually encourages extra-legal conflict resolution. So reduced trust and safety created these reinforcing cycles where instability and disconnection amplifies violence. So even though more policing might initially lower violence, it can then worsen long-term outcomes by reducing cohesion, increasing fear, and driving gun ownership. So fear of violence actually promotes and prompts greater gun ownership, which further escalates violence and creates the feedback loop again that perpetuates insecurity and harm. So participants really emphasize addressing the perceptions of safety and fostering trust to disrupt these cycles. So that's an overview, again, of that very kind of complex model. But you can see how, right, there's these short-term fixes, that might temporarily reduce gun violence in the short term, but longer term, these are the things really over time that are driving persistently high rates of gun violence. So we then worked with the group to use the model to find places in the system to intervene. And many of those I already shared with you. They were outlined in green. But we talked not just about, what we might do, but rated them on how feasible they are in our community, how impactful they might be, as well as who else we would need, to galvanize around these issues or to implement a specific intervention. And so we also did stakeholder analysis of other, community partners or potential stakeholders, how much power they have around the issue, how much influence they have, and if they're kind of for or against these various issues. So again, these are just kind of quick pictures of some of the things we did in the room, where they identified some key potential leverage points based on the models and actually started to map some potential initial interventions. So in the end, we landed on a multi-level intervention that we call True Haven. We actually have funding from NIMHD right now, where we're implementing and testing it across 7 different neighborhoods in New Haven. It is a type 1 hybrid effectiveness implementation study where we are rolling it out as a stepwise study design across these neighborhoods to compare the effectiveness of the program versus conditions as usual, and then essentially using the REA model to examine a lot of implementation metrics. And then we're utilizing our system dynamics model to project the long-term impact of True Haven beyond, the 5 years of an NIH grant. So this is the program itself, where we are combining an initiative to improve housing stability. Again, home ownership and social cohesion was really critical in the model. So participants from these neighborhoods have access to housing assistance programs and tailored financial education. And we're pairing that with community mental health support, where we're training a trusted network of people that live or work in these neighborhoods in trauma-informed counseling. And so it's this combination of these 2 interventions that we're rolling out to these 6, it's actually now 7 neighborhoods. And we're specifically targeting for the housing stability part of the program, 1,400 families that are affected by incarceration. This is to kind of concentrate our efforts among groups that are more likely to be affected and impacted by gun violence. And we define this as either people who have been recently released from prison or family members of people that are currently in prison. So I already mentioned most of this stuff. It's a cluster randomized stepwise design, and we're using CFER and REAIM really to assess the implementation metrics. I can't yet share with you the findings because we're still recruiting. I'm still blinded to the results. But what I can say is, that some of the interim findings are very promising, especially of the group of people that we've enrolled in the housing assistance and financial education programs. Some of these people were completely unbanked or had very poor credit scores, and we're really able to improve those over time. So, I mean, in some ways, regardless of what we see for the ultimate outcome of gun violence, if we're able to improve some of these families' lives, I think that even alone is a big win. All right. So I know I'm moving kind of fast, but I want to at least give you an overview of the second example of community clinic linkage. I will go through this one a bit more quickly, but this is kind of a shift in topic where now in Brooklyn, New York, where I'm currently based, we are working with really a predominantly low-income immigrant community, and where social determinants of health have pretty significant negative health effects. And community clinic linkage models are collaborative efforts between healthcare providers, community-based social service organizations, and public health agencies to really comprehensively address health and social needs. And they create more of a continuum of care across clinical and social care organizations and have potential to improve health outcomes. So, and maybe I'll step back here for one moment just to say that this is a great context for system dynamics modeling or complex systems modeling because it inherently is asking for the design and linkage of multiple different types of systems, right? We have the health system, we have, CBO and social service systems, as well as public health systems. And now you're trying to actually create a meta system across them. And so for that reason, group model building and system science is really useful to understand how best to link these systems from a structural perspective, but also what kind of workflows are really needed to support a really diverse and high need population. And so this gives you a little snapshot of our local community here in Sunset Park, Brooklyn, where, it's roughly close to 150,000 people, but half are born outside of the United States, and three-quarters speak a language other than English. It's roughly, of those 50-50 Spanish and some type of Chinese dialect. And supporting this community is a federally qualified health center that's part of our health system. Um, and the family health centers, which is the FQHC, are very comprehensive. They include primary care, school-based health centers, behavioral health, obstetrics, and specialty care. We also have, as part of that, the Family Support Center, which is a multi kind of social service center for local community members, not just our patients. In addition to many community-based organizations that similarly provide multiple social and immigrant services, and the hospital system, which is NYU Langone Hospital, Brooklyn. And so we engage people from all of those groups in multiple different fields, in addition to our data analytics, IT folks, in 2 half-day group model building workshops. It was a much larger group. It was 30 to 40 people kind of representing these different sectors and perspectives. But again, they work together to map how social needs are currently assessed and addressed in the existing system. And we work to really elicit barriers and facilitator to addressing these social needs. So in the first day, they worked in small groups to develop causal loop diagrams. And in the second day, we actually brought back a synthesized causal loop diagram that they refined and started to brainstorm interventions. And so this is kind of an overview of the synthesized causal loop diagram, where the blue arrows are like the community part of the system, the purple arrows are the clinical part of the system. Then in the green is like the informal, so social networks. And then finally, the yellow is the kind of more formal community clinic linkage that needs to be creative. And we noticed that there are parallel dynamics of care seeking, service provision, and capacity strain across both the healthcare and the social service settings. And leveraging word of mouth can be an important informal way to promote care seeking. And capacity can be reinforced in our systems through cultural and linguistic tailoring and knowledge of the community context. We also found it was really important to develop strategic coordination and actually have resources to support coordination between social service providers and healthcare providers, but that is currently constrained by capacity. And so in addition to utilizing group model building, we also used human-centered design at the clinic and organizational level and system dynamics modeling to really blend the two to actually model social needs screening and referral workflows and simulate potential workflows to really identify like the best sequence of steps to implement this community clinic linkage. So this is some of the human-centered design thinking approaches that we used. First, we actually just mapped out, like from the patient and family perspective, what does the workflow look like if you are at a clinic visit, have a social need identified, get referred to a community-based organization, really outlining that experience from multiple perspectives, including the clinical staff themselves, as well as the patients and families. And some example insights from this were things like the importance of the strength of trusted relationships, the value of warm handoffs between clinical and community settings, the reality of capacity constraint downstream at our Family Support Center and our partner community-based organizations, but also how challenging it is for providers to feel like they can't sort through all the potential resources to make a referral, and they don't know what happens after they do. And that's a really scary feeling for our physicians. So it was essential for us to think about like a hybrid approach to get about the value of the warm handoff with the value of coordination from a more like centralized referral system. So then, as I mentioned, we operationalized our assumptions about the way patients flow through the system and explore the impacts of changes to capacity dynamics and tested the impact of some of our emerging ideas to improve the system. And so here are like a few different scenarios that we tested, and you can actually see like what the graphs look like, over time, and how it impacts like the average wait time for social services, or the rate of social needs referrals, from one clinic, for example, or the total number of people that are going to drop out of the system before getting their social service. So this basically illustrated the potential exacerbated bottlenecks if we suddenly increase the rates of social needs screening. And some of our recommendations were really to increase capacity first, right, at our community-based organizations so that they are able to receive referrals before we increase screening and referral. We also modeled how to sequence the rollout of screening and referral and coordination across the various constituent organizations. And so this is kind of an overview of like our final key insights to implement our community clinic linkage locally. So we have a staged approach to increasing social needs screener completion and developing multiple options for screener completion. So we also don't create bottlenecks on the clinical side. We really saw the importance of clarifying roles and distributing tasks for social need referrals, and developed a hybrid approach to actually managing those referrals. As I mentioned earlier, we noted the real importance of investing in the social need service delivery capacity, and of course, their ability to serve very unique and diverse parts of our population. And then finally, looking at different types of inflows to care bidirectionally, actually, both to social service and to the healthcare side. So that's what I had to share with you today. I hope that I have conveyed that participatory system science can be a very useful tool to better understand and design interventions for really challenging public health problems. I went through two examples that used participatory science effectively, also integrated with other methods to design and implement interventions. We talked about one intervention, a multi-level intervention to address community-level gun violence, and then another intervention to implement a community clinic linkage in a diverse, low-income immigrant community. So really want to thank you for listening, and I hope we have a little bit of time for questions.
Fantastic, Dr. Roy. Thank you so much for this amazing presentation. Really, really mind-blowing. I'm going to start us off with a question just because I have one, and I'll let others think about it. We'll have about 9 minutes for questions. So I love the systems dynamics models that you shared. And my question is actually related to how you're using participatory methods and participants to help build those models. My assumption is that sometimes having those models with the pluses and the R's might be confusing for participants. And I'm wondering if you've used those models as illustrated successfully with participants, and if there's sort of a learning curve to get them there, or if you use more cartoony drawing on whiteboard ones that are maybe less academic in those community meetings.
Yeah, so it is both. So actually, to construct the models themselves, I have the participants do it. So I teach them the notation and actually show them how to link variables causally and think about the directionality, right? And they themselves will write the plus or minus and start putting it together over time. So it does I mean, these workshops were fairly long, right? We're talking at least like a full day or a couple days, total to construct the model, but they're all in it and part of that process. So if they're part of the process, then it's relatively easy to bring it back to them to refine it or, dive maybe into more detail in a specific part of the model. But uh, if I am then talking with, let's say, another stakeholder group that wasn't part of that process, then I will use a more simplified, kind of stylized version to explain it. If they want to see more under the hood, we can always show it. But yes, if someone wasn't actually part of the process, I do find it difficult to show the whole thing and really have them understand. But there are ways to simplify it and really, but at least still get people to understand the nature of feedback loops, and why something that feels maybe like it might be 2 or 3 steps removed is actually a really important part of the problem.
Amazing. Others, questions?
Fred?
Has a question?
Um, Dr. Roy, terrific work, really fabulous and fascinating, insightful. I love the modeling. I had two questions. At the beginning, you talked about using actual numbers in there, and um, I wonder where some of those come from. Do you talk to the people and say, how much does your lack of access to food or your engagement with a gang on a 1 to 10 scale, and that assigns a weight to one of the circles? And the other is how you begin to think about, and again, maybe this is a bit much too big, that each of these wicked problems, the inputs to it are wicked problems, and those have wicked problems. That how do you know when to intervene on one thing to how much that's going to be affected up and downstream? Anyway, that's really complicated, but it really
Yeah.
is beautiful work. So thank you.
Yeah. Yeah, both excellent questions. So for the first, actually parameterizing a model. So first I'll say every single variable that is in the causal loop diagram, the qualitative version, does not get mapped like 1 to 1 into the quantitative model. That said, in the quantitative model, we use existing data where it exists, right? So let's say for the gun violence model, for example, uh, staying in school. So middle school and high school um, student populations, as well as graduation and dropout rates, were an important part of the model. And I have numbers, right, that I can put on those. I also have number of gun violence events and shootings, right, over time, over the years that I can actually put into the model. But yeah, there are other things like um, level of trust, let's say. Maybe I have a survey. I mean, in this case, we were fortunate to have a community survey that's been done every couple of years to be able to use a number. But if I didn't, then absolutely, what I would do is work with our community partners, right? The stakeholders that are involved in the process and say, okay, on a scale of 1 to 100, right? What do you think? Like, how would you have rated trust? Or I mentioned social cohesion was really important. Back in 1960 when you were telling me everyone knew each other, right? And then what about in 1980? And then what about in 2000, right? And they actually can kind of tell you like overall magnitudes of how they think it's changed over time. So we will actually use kind of more, I don't know, you can call it fuzzy, but it is data, it is information, and it's a sense of real people living on the ground of how things change over time. So sometimes we do have some factors in there that are maybe a bit more subjective. And two things to that. One is we'll run sensitivity analyses. So I might set it at whatever, on a range of 1 to 100, I'll set it at a 50, but also just test what happens if I go up to 75 or I go down to 25, right? To really see, what that does. The other thing is, the model itself overall is not that sensitive to a specific change in one variable. it is the structure of the model that's more important. So even if you get one thing like slightly wrong, or it's not exactly a 50, it's actually a 65, it doesn't change the inherent like dynamics of the model, and the outcomes over time as much as you otherwise might think. So we can actually test those things in sensitivity analyses. The second part of your question is, well, what about the fact that these are like, interrelated and, other wicked problems, at the root of a lot of these. So I've done this kind of a similar process around, gun violence or similar issues now in multiple communities, right? Of course, underlying all of this is poverty and, and structural racism and like, right, who is experiencing these issues? And there are some commonalities to that, and that is, kind of a very deep-rooted, complex issue that cannot be solved overnight. So it itself is its own wicked problem. It is, I mean, you do have to set a boundary to your model, what is included and what is outside of the bounds. You'll see still some of those factors, right, are in there: financial stability, housing stability, access to social services. And those are some things we can influence. We can also influence how the government like prioritizes, especially local government prioritizes funding for various things. So we try to include things that at least we have some ability to change, and acknowledge that there are still some external factors, that we can't. But the goal is to be able to make some change in a positive direction, still, within the constraints of the larger system that we're in. See one other hand up.
Hi. So I'm a pediatrician. So as you were presenting, I was thinking about how could we apply this type of thinking to immunizations or vaccinations. And as you may be aware, their population of group that you want to impact may not have the same goals as you do. So how would you, what's your view on how to work with that population when you're doing something like this?
Yeah, so I actually find it to be a really useful tool to work with populations that have very differing viewpoints. Again, it helps different people see different parts of the model, the system, what influences it. Cultural perspectives and beliefs can be part of the model and are often an essential part of the model. And so it might even help you like understand their perspective. It helps them understand your perspective and start thinking together, right, about how best to move forward. I didn't get into all of this, but Donna Meadows is like one of the leading thinkers in systems thinking, and she maps out like different levels of power of leverage points. And group model building, or this kind of systems thinking, one of the most powerful ways it acts is actually by helping people shift their mindset and paradigms around certain issues. So even the process itself, as I mentioned, like can actually help you build a coalition, and it can help people understand other perspectives that they might initially think is very counter to their own. So I would encourage its use, and some concrete examples like from this work, or another one I did recently around incarceration is like we had people from law enforcement, alongside people who were previously incarcerated, and like they had to have some direct conversations. It's part of the reason we want this to be really structured and systematic, so it doesn't, get out of hand. But people can have differing viewpoints and some difficult conversations, but in a way that is respectful and actually still moves the ball forward.
Awesome. This is amazing. I'm going to wrap the meeting up because I think many of us need to run to other meetings. Dr. Roy, I really appreciate you spending time with us. And thank you to everyone who's taking time out of this busy end of the semester holiday season to join us. Vanessa will share the recording of this on our YouTube channel. And it sounds like there's a few cool opportunities for some of us to follow up with you, Dr. Roy. I really appreciate this.
Yep. Thank you all.
Thank you so much, everyone. And happy holidays, and see you in 2026.